So we started with stroke recently. We have classified stroke. Basically, we have got two important categories. One is ischemic stroke and another is the hemorrhagic stroke. Both stroke they causes problem, and most of the signs symptoms they appear they are almost same. We have seen some of the diagnostic appearances, and we have made them as abbreviated as a fast. Then we have seen what are the conditions, what can be the reason. Example of these are transemic ischemic attacks, and then we have seen rosier earlier when we have seen gone through the presentation. Now once we understand, we go and then another diagnostic tools we have got. These are basically from various scanning methods, maybe CT scan or imaging method rather we call it. So CT scan or MRIs. So these are various tools which helps apart from the physical signs. And on that basis, we are recognizing the symptoms and go for diagnosis. Basically, when we say that is facial arms and related all shoulder related activities or fast, we abbreviate it as. Basically, we can see that it's sort of paralysis depending on the area where the hemorrhage or ischemia is there. And on that basis, we can go for various scanning or screening methods, and from that we can see that how it can be causing. So in that case, when we go for this, then we can understand it can be of any kind. It can be of either hemorrhagic kind or it can be on the ischemic type. Now once we understand this, what kind of it is, then we can go for that. We can check what are the activities which are there, and we go for optimization of medication on that basis. Just now, what kind of this may be, what kind of problem it may be. So we have seen it can be either no transient ischemic attack. So we can start with the primary prevention. So for that we can basically we have got risk factors. If you remember earlier, we have seen it. So these risk factors are hypertension, diabetes, age, and these are the scales are given for that to identify. So on that basis, whether the person is having a higher age, the person is having diabetes, the person whether smoking, so any kind of reasons are there, then obesity and sedentary lifestyle, etc. So all on that all basis we understand the risk factor, and on that basis we can give the preventive or prophylactic treatment before exactly it is happening. But when there is a transient ischemic attack, then what we can have is we can have once we have the suspicion that there is a transient ischemic attack, then we will go for initial management for that. Initially what we can do is again for that I don't know how many of you, means I am not clear about it, how many of you have completed the assignment. I could see few, I have not counted exactly how many are there, but those who have completed, they will realize that how beneficial it was. So when we say that it is ischemic, we know the reasons for ischemia. We have seen it earlier in pharmacology of second year, we have seen it in the therapeutics of second year, that what are the reasons behind ischemias. So most of the time it is because of the coagulation of blood, and therefore we need the agents which can prevent it, which can do this, that whatsoever clot formation is there, it is minimized. So in that whatsoever treatment you have seen, we can understand. We have seen aspirin as an antiplatelet agent, then clopidogrel as an antiplatelet agent, Then various agents like warfarin and various what we can say anticoagulants of variety of kind. So we know about this. So these are the treatments. So first treatment is there, that is offer aspirin to this patient unless it is contraindicated. We have had a suspected transient ischemic attack. It should be started immediately. Then again this patient are to be referred immediately to specialist assessment and investigation within 24 hours of the onset of symptoms. The scoring system we have used earlier, A, B, C, D, 2, isn't it, on the basis of age, blood pressure, then other problems, then age, diabetes, etc. So on that basis we have had the scoring system, but don't use the scoring system to assess the risk subsequent to stroke or inform the urgency of referral to patient who have suspected or confirmed because already it is there. Then there is no fun in going for the scoring system. Scoring system is before that, we have seen it before there is a transient ischemic attack. Before that we can have the scoring and accordingly we can give the prophylactic treatment. Then offer secondary prevention. In addition to aspirin, we can offer various treatments. As soon as there is a diagnosis of transient ischemic attack is confirmed, then we can go for the parallel treatment. Then next is the go for brain imaging. I told you CT scan or MRIs, etc. We go for that. Here we are not going for CT scan with suspected transient ischemic attacks unless there is a clinical suspicion of alternative diagnosis that CT could detect. Because if already the thing is clear, then it doesn't mean it is going to harm, but it unnecessarily waste of time and money. So when you are diagnosed it earlier, then do not go for CT scan. But if you want to know details that what may be the reason or what kind of damage it might have caused, then definitely CT is going to help. CT, you know what it is? Anybody? What do you mean by CT scan? Anybody is aware about CT scan? What is the meaning of CT scan or what is the full form? Very good, computed tomography. What it mean? What it mean? Okay. Fine, still go for details. Basically it is a X-ray technique, only thing is it is computerized and it can have several slices. X-ray is almost 2D technique, this becomes 3D technique, so that multiple slices are there. And apart from brain imaging, when you are going for MRI, MRI is much better one. Basically you ask for diffusion weighted and blood sensitive sequences. Then this yes, so that's what I told Riddhi, that is normal X-ray is 2D one, it gives 2-dimensional one. This gives around 3-dimensional structure. So if MRI is done, it has to be done on the same day. It is a better one. So it can detect what can be the reason, what is the area of the ischemia, how much is the infarct size, because it will cause infarction in that area. and ischemic injury, how much area is there. If it is hemorrhage in that area, then it will be also detected, and accordingly it will become easy for further diagnosis. Then check whether there is a carotid stenosis. Stenosis, you know about it, is a hardening of the artery because of the deposition of various things including calcium, and because of that that becomes rigid. Because of that, the elasticity of arteries are lost. Later stage it becomes as atherosclerosis. So what it is there, what is the reason behind that, and if it is stenosis, then go for treatment for that. The best treatment for blood pressure, antiplatelet agent, cholesterol lowering agents, to diet and drugs, lifestyle advice. Now here you will find that treatment is almost matching to that of myocardial infarction or angina, because the thing is only organ is changed and therefore symptoms have changed, but basic underlying mechanism of disease or mechanism behind the disease or etiological factors, they are same. That is what these are the factors which are contributing to atherosclerosis or stenosis. Only name of artery is changing. Here it is the carotid artery, there it is a coronary artery in heart. So basically most these things are similar. Therefore I ask this homework that please go through all the treatment for angina, particularly atherosclerosis, drug acting on blood. So go for that. When the patients are having stable neurological symptoms from acute non-disabling stroke or transient ischemic attack who have symptomatic carotid stenosis of less than 50%, then this is a criteria, that is NASCET criteria. These are various criteria are there, that is North American symptomatic carotid endarterectomy trial criteria, that is that arteries are then cut and sort of bypass is done. So there are various teams, that is whether it is NASCET or this ESET is European carotid, they have slightly variation in guidelines, and they suggest that at certain places one can go for surgery if it is more this one, but if it is less than 70% stenosis, then do not go for surgery. Receive best treatment for blood pressure, etc., as we have seen earlier, and have the imaging of the carotid one. Then go for stenting. Again, just like as I told you, I am repeating this again and again, just like in myocardial infarction we have done stenting. Here also it can be, if it is not very deep cerebral artery, we call it as a mid cerebral artery, MCA. Earlier we have seen the abbreviation. So when this mid cerebral artery is having this stenosis, because of that thickening is there, there is atherosclerotic plaque, and because of that there is ischemia. So in that condition we can go for two things, either bypass, that is that much portion is removed and new piece is attached to that. So we call it as a endarterectomy, that is this arterectomy, that is that much artery is removed or that portion is removed which is having. But it may not be possible because that is a very complicated surgery it is having, usually not preferred. So in that case stenting can also be done, and but when stenting has to be done, again it has to be taken care that basically it cannot be reaching too inside the brain, because only up to certain level, up to certain branching of artery rather I can say, they can go for that, and in that it can be there. So this is one of the best treatment, that is go for the stenting of that. Now there are various ways by which one can go for this stenting. We are not supposed to go for the detail of how the stents are inserted, but yes, stents are inserted, and there are variety of stents are available, just like cardiovascular system you have seen, and go for that. Intervention which should not be used is there are intracranial bypass for intracranial atherosclerosis, extracranial to intracranial. We cannot have this kind of bypass, that is blood, because we are bypassing the blood-brain barrier also. Extracranial means which is from outside, and then this blood is going to inside the brain. We call it as a extracranial to intracranial bypass. So that is not uh, recommended, which is not to be used. Okay. uh, Preventing the further occlusive, this one again, as I told you, you might have studied all this treatment. Clopidogrel and modified release dipyridamole, these are the treatment. Only difference, biggest difference with the cardiovascular system here is use of dipyridamole. Anybody remember dipyridamole in angina, whether it is used or not, and use of dipyridamole in angina? Yes. Okay. It is used as a vasodilator in angina. Okay. Okay. Fine. Although it is there in books of pharmacology somewhere, you will find very good information about it. Dipyridamole is not preferred in angina because it causes a typical effect, that is causes a steal effect, STEAL, steal, that is stealing, chori. And why? Because it causes vasodilation of nearby blood vessels. Definitely we are using vasodilators, but here what happens is it causes vasodilation of multiple vessels except those which is affected. And you can imagine what will happen if these blood vessels are dilated, then blood will go into these vessels, and already there was ischemia because of that artery, that will not be resolved much. Fortunately in brain it does not do like this, so it is preferred in brain but it is not preferred in angina. This is what the reason is. So dipyridamole is recommended as an option to prevent occlusive vesicle event for the people who have had transient ischemic attack, particularly only if it is used if aspirin is contraindicated or if it is not tolerated, because aspirin we have seen it as a first choice. People, or then it can be added to aspirin if we need a combination. Okay. These 2-3 drugs are there, that is clopidogrel. Clopidogrel is very prominent, you can find in almost all angina and other treatments which are there. Okay. Then implantable cardiac monitors to detect atrial fibrillation after cryptogenic stroke. Cryptogenic means where we could not understand the reason and we can check whether there is atrial fibrillation. Do you remember I asked this question, what is the role of atrial fibrillation and stroke? Anybody? I think I asked this question. Or I think I discussed this also. What I can recall now is this. Okay. If you cannot recall, go through it. Go through the relation between particularly atrial fibrillation or atrial flutter and stroke. Okay. I am very sure I have explained it once briefly, maybe almost just given a point to consider it. So go through it and just let me know if you have understood this condition. Okay. So why we are going for monitoring, or we need a treatment in many cases before stroke we go for, or we need the treatment for the arrhythmias, okay, that is particularly atrial arrhythmias. So go for prevention of this, prevent how we can prevent the further events. So we'll add various treatments for that, as I have seen. So this is how we are going for the treatment for transient ischemic attacks. Now there are chances that person may have acute stroke. That is, there was no previous transient ischemic attacks. Example, now again, if we need to go for, we have to compare it. That is, transient ischemic attack related to brain is something like angina in heart. That the person has got particularly angina, that to be suppose a stable angina. Stable angina means only during exercise the person feels that something is wrong, and when the person goes for the exercise related test, then he identifies that there is a problem. However, here also, when the person is having some activities, and then at that particular point the supply decreases, and then he shows the transient ischemic attack signs, that is confusion, muscle incoordination, and maybe one side muscle problems, FAST we have seen, or Rosier kind of syndrome, that is stroke related whatsoever activities are there. So when we identify this activity, then we can think about it, and here the damage is not much done. Okay. However, when there is acute stroke, here we can compare it with somewhere with myocardial infarction. I hope those who have studied it earlier, I think they can just go for this angina again and myocardial infarction again. So the difference is there. Difference is myocardial infarction is all of a sudden because it was not expected, and it becomes very severe many times. While when transient ischemic attack is there, it is not that much severe. It gives just warning, it gives information just like angina gives. So when it is there, a person with suspected or confirmed acute stroke when comes, then go for this confirmation. For confirmation using brain imaging. So either we are going immediately with the non-enhanced CT for the people with suspected acute stroke, or MRI, whatsoever possible, go for that. And these are various signs we can have. Indication of thrombolysis can be there, whether possible, because again here also time is very important. If the symptoms are there and within 1 hour there you have got highest chances of recovery. So this is as fast as possible one has to act and see that if this person is fit for the thrombolysis or thrombectomy. Thrombectomy means removal of thrombus surgically. Thrombolysis means we have got thrombolytic treatments, that is recombinant tissue plasminogen activators. We have seen them earlier. We can again go through it. Use whether check the person is whether on anticoagulant treatment already. Suppose the person has some transient ischemic attacks previously, and now if the treatment is going on, then you can think about it. You can check whether there is any bleeding tendency in patient. What is the level of consciousness? If there is a scale is there for general consciousness scale, we can call. If it is below 13, then we can say that it has reduced too much. Unexplained progressive or fluctuating symptoms are there in the people. Papilloedema, neck stiffness or fever can be there. Severe headache at the onset of stroke symptom the person may be experiencing. And if thrombectomy might be indicated, go for imaging with CT contrast angiography. That is, it will give the dark thing with stenosis. We have seen stenosis one of the reason. So this will contrast will give the stenosis areas sites and check whether it can go for surgery, that is thrombectomy. Following initial non-enhanced CT, add CT perfusion imaging for this MRI equivalent if thrombectomy also be indicated beyond 6 hours of the symptom. Usually beyond 6 hours, usually they are not recommended. It is as early as possible, maximum 2 to 3 hours. Perform scanning as soon as possible, and within 24 hours of the symptom, everyone with a suspected acute stroke should have immediate brain imaging, and immediate what we can say treatment should go for. Now in imaging you will realize what kind of situation it may be, whether there is any kind of intracerebral hemorrhage, then it should be monitored by specialist in the neurosurgical or stroke care for the deterioration of function, and referred immediately for brain imaging wherever it is there. So why this is? Because sometime it can be very complicated issue, that because of the stenosis or because of that there is a rupture, and this rupture result into hemorrhage. So it is actually both, it is ischemic as well as hemorrhagic, and this is the most complicated thing the stroke specialist they face. It can be in very few cases, but yes, it is most challenging condition, because for ischemic you have to give the drugs which causes decrease in the what we can say blood coagulation. Okay. And so, and if these are given, then they are increasing the chances of hemorrhage. And for hemorrhage we have to, if we want to control, we have to give some coagulant, and if these are given, then they are increasing the chances of ischemia, or they are increasing the chances of coagulation of blood. So that becomes very typical situation which the clinician has to handle, and then they titrate it in the meanwhile, that is either topically or specifically applying the anticoagulant or antithrombic treatment at one place, and trying to control the blood supply at other place. Maybe they are going for surgery depending on the conditions, and this they are trying to handle it in that way. So once they have got the brain imaging, they have diagnosed it, simultaneously go for supplemental oxygen therapy, because patient has to be immediately there. So their oxygen saturation, if it drops below 95, usually it drops, but most of the patients require it. Routine use of oxygen supply is not recommended with acute stroke who are not hypoxic. So only in hypoxic it should be given. Maintain the blood glucose concentration between 4 to 11 millimole per liter in people with acute stroke. That is what we call it as around 60 to 70 to around 100 mg per dl. Provide optimal insulin therapy, which can be achieved by the use of intravenous insulin and glucose. The adult with type 1 diabetes with threatened or actual stroke, in that case you are using for this insulin and glucose simultaneously, because glucose is required and insulin is controlling the blood glucose level. So even in myocardial infarction, if you have read somewhere, you will find, or you can read even now, that is very popular therapy is there, that is called as GIK therapy. That is G means glucose, I means insulin, and K means potassium. These three will be helping the people more comparatively, along with the antithrombic treatment. So this is how we are going for this blood sugar control has to be there. The levels has to be maintained, so that glucose is available for energy production, insulin is available if it is less or if it is a diabetic condition. So insulin is available for improving the utilization of glucose, okay, and both should be there, so that the glucose level is controlled. Now once we have now this is done on the symptomatic basis, we have diagnosed it using imaging, and we have got some of the outcome, either it is a ischemic stroke or it is a hemorrhagic stroke. So if it is ischemic stroke, then what will be the our situation? Okay, if we got the person with suspected or clinically confirmed stroke, then what will be our treatment options? So it can be thrombolysis. Which drug we are using? Thrombolysis, alteplase only. We are not using any other drug. We in myocardial infarction, if you remember again, we have used the thrombolysis with other RTPs, that is recombinant this plasminogen activated. So these tissue plasminogen activators. So these RTPs are there, we have seen them earlier. Here alteplase is the first choice, and we are not, or it is not recommended to use other kind of this TPS. So it is recommended when okay, it is started as early as possible, that is within maximum 4.5 hours of the onset of stroke symptoms, and intracranial hemorrhage has been excluded. See, I told you this is really complicated. Just now I told you, if it is hemorrhage, it has to be diagnosed, and if it is hemorrhage, then you cannot give this alteplase, okay, because it will complicate it. So intracranial hemorrhages has been excluded by appropriate imaging technique. Appropriate imaging techniques you have seen, either CT scan or MRIs. So you alteplase it, administer it. It is only within a well organized stroke service, when staff is trained, when everybody is expert in that, then because just like again I am always telling or I am always trying to compare it with myocardial infarction. In that also, if you are using this, then you have to take more care, because initially it can cause a very risky situation, and you should have various measures immediate available for the controlling emergencies. So they should be, if the trained staff is there along with the sign symptom, they can judge it, and accordingly fast treatment they can go for. This protocols are there, blood pressure monitoring etc. are done in that, and accordingly one can go for. So after alteplase, the thing is the normal maintenance, what we can say. So for that, aspirin and other antiplatelet treatment is given. We know about it, aspirin 300 milligram orally in various divided doses by various routes, or along with that clopidogrel or dipyridamole. We have seen them earlier in transient ischemic attack, and same thing we can continue with that. So these will be the treatments for that. Thrombectomy, I told you that that removal of thrombus from the blood vessels, or removal of portion of the blood vessel which has got severe stenosis. This should be there. Acute ischemic stroke, and go for confirmed occlusion of the proximal anterior circulation. This demonstration. So check the areas, you check with the CT scan or MR, and accordingly go for this. Check the clinical status of the patient, how it is, and accordingly you plan it. Again I told you, it is thrombectomy is not that easy. Any brain surgery is not easy, because any injury to brain is difficult to repair. Neurons, you know, they are not undergoing any kind of cell division, and therefore if they are not going, any injury that happens, that can be permanent. So if it is very emergency, then only this thrombectomy can be done, and that too with having minimal invasive surgery or minimum damage to that. And for that, nowadays various microsurgery skills are available, and where the doctors can use or we call it as a robotic surgeries, where just small probe goes inside, a very small one, and just remove some portion with very thin type of cutter is there, very thin. So this thin cutter just scraps tissue and then we can get it. If you remember this term, we have used ablation of tissues earlier. Similarly, we can use this, and this microsurgery is basically used for that. Then go for therapeutic hypothermia, that is decrease the blood pressure, decrease the body temperature of the person. So during that, this hypothermia is there, but it is not done in case of acute strokes, acute ischemic strokes. Usually we do not go for this kind of hypothermia. Then antiplatelet, again we are having several anticoagulants, and as we have seen that what are the drugs which are there. Then again treatment for these arrhythmias, as I told you, what are the reason which are causing it. So these arrhythmias we can control because they are contributing too much for this embolism because of this atrial fibrillation. Okay, so go for this antiplatelet treatment. For that we have seen antiplatelet treatment, aspirin, again clopidogrel, dipyridamole, etc., and they will be helping, they will be useful in the patients. Then next is control the blood pressure, because it is one of the very important contributing factors. Rather, we have seen earlier that it is one of the important atom in the risk assessment scales. We have seen ABCDD2. So in that we have seen blood pressure becomes one of the important contributor, and it can result into various problems like hypertension, encephalopathy, hypertension, nephropathy, hypertensive cardiac failure, myocardial infarction, aortic dissection, eclampsia. These are the various conditions, and therefore blood pressure reduction monitoring, it can be very important contributor in the treatment. So these are various treatments, and then all these treatments one by one or simultaneously we can utilize it. Then go for the various stroke guidelines. For that, what we are doing here is, once the person is administered, then we assay it. We go for the fast evaluation, that is facial, arm swallowing, etc., whether it can possible or how difficult it is. On that basis we judge it. We can have optimal positioning and early mobilization, whether person can have the mobilization. Simultaneous statin treatment can be there. Why statin? Because most of the people who are having hyperlipidemia, and hyperlipidemia contribute a lot to atherosclerosis, and either any of the vital organ is damaged because of that, either heart or brain, they damage because of that, and it results into either heart attack or it results into stroke. So therefore we are trying to that reduce that chances of having hypercholesteremia or hyperlipidemia. If we control the hyperlipidemia, then the person will not go for stroke, and if it is not stroke, or it is not go for atherosclerosis, and there will not be any stroke. Consider the decompressive hemicraniectomy. I told you what is a decompressive. If you remember, decompression is a sort of surgery, is opening of the skull. Why we are opening skull? Because whenever there is a acute ischemia was there, or ischemic stroke was there, and acute was there, then that much area will be damaged because of the ischemia. We call it as ischemic injury. Whenever there is an injury, whatsoever kind, immediately inflammatory cytokines they reach, they causes inflammation, because inflammation is rather part of homeostasis, it is part of a repairing mechanism. So inflammation always occur. If inflammation is occurring, then the size will increase, and because of the presence of skull from all sides, it will get compressed, and this compression can cause further damage. To avoid the doctors go for surgery to what it is called as a decompressive hemi means half craniectomy, that is removal of that is skull bones. So these skull bones are removed for some time, and this skull bone, after the brain inflammation is over, brain goes to normal size, then this is again sutured back, it is again packed back. So it is when it is done in the patient with acute stroke who met all of the following criteria, that is there is a clinical deficit that suggests that infarction in the territory of the middle cerebral artery, and the score is 15 or above in the scale, that is we have scale that is National Institute of Health stroke scale. So when the stroke scale show the score of 15 or above, that means that it is in the middle cerebral artery, and then it is causing clinical deficits, that is the normal day-to-day function deficits are there, and in that cases then we have to go for decompressive hemicraniectomy. Decreased level of consciousness with score of 1 or more than atom one way of NIHS. Signs of CT scan shows the infarct size of at least 50% of the middle cerebral artery, and it is with or without any additional infarction. So these are various criteria. Then there is an infarct volume greater than around 145 square meter, 145 meter cube, centimeter cube. That much area is there. We call it as infarct size. And particularly when we go for diffusion weighted MRI scan, then we'll realize that if this much is damaged, then go for this decompensatory hemicraniectomy, that is removal of brain. If one side you remove, the only thing is brain gets space for inflammation. Just like I told you, if your hands or legs get inflamed, then you have got space that it will get increase in the size will be there in this what we can say, in the air it is there because there is nothing which is stopping. But suppose you wrap the hand tightly, and if there is inflammation, then this inflammation will go inside and it will damage internal tissues, because outside there is no space for this. Similarly, this happens in brain. So we need this decompression we call our therapies. Then there are various risks and benefits of this, and it should be told because it is comparatively happens in a very severe cases when these patients are not of they are already lost their consciousness, and they are found difficult to treat. In that cases, this decompression is there, and taking account to their functional status before stroke and wishes and preference of the family member, we can go for that. Therefore, the patient and relative decision will be important in that. Who are referred to decompressive hemicraniectomy should be monitored appropriately by trained professionals who are skilled in the neurological assessments, and accordingly all the parameters are continuously monitored, and if the patient regains the things, then this skull may be put back, or otherwise till it is inflammation it has kept away. Assess the managing the carotid stenosis, and it is disabling the ischemic stroke. So in that check the carotid stenosis. I told you we have got variety of ways by which we can judge the carotid stenosis, various imaging techniques, etc. And if we found that there is a stenosis, again we have got two options: treat for it, pharmacology, or remove it surgically, and put some stent into it. So these are various options which are applied, which are used into this. Okay, then next is manage deep vein thrombosis. DVT you might have studied last year in third year. So what's the treatment is there, or usually if deep vein thrombosis is not well treated, or pulmonary embolism is not well treated, then it reaches to brain and it can cause the stroke. be very sure, be very clear about it that whenever the chances are clotting are there, they are increasing. Blood is actually circulating into all the areas and definitely maintaining some barrier functions. So when there is inflammation, then at some time this barrier function is lost. The inflammation is going up to the various deep portions in the particular tissue or organ, and then it can cause more damage. So in that cases, deep vein thrombosis, whenever it is there, from that these thrombos are there. If it is not properly treated, this thrombus can circulate and it can damage anything. It can damage heart, that is myocardial infarction. It can damage kidney, that is ischemic kidney attach. It can damage the respiratory system. Anything it can damage. And on that basis, if it is going into brain, then definitely it is going to cause the stroke. Okay. When you are managing that, there are even chances, because if the person has got deep vein thrombosis earlier, and if the person is treatment with this antithrombin agents, etc., then this patient have more chances of hemorrhage and can cause hemorrhagic stroke also. So therefore, depending on the condition, after clear diagnosis, one can go for the treatment. There are certain, we have seen about that intervention that could not be used is intracranial to, this is means outside the cranium to inside the cranium. We cannot create that kind of bypass, because we are then disturbing the whole important mechanism of bypass, by which brain has formed various flowers and valleys and what not. So I am sure you will get through it. You will find it interesting that how these agents are acting. We have seen about this as a prophylactic treatment for future, that is clopidogrel or aspirin and dipyridamole. Same, whatsoever we have seen in transient ischemic attack, same thing is there. And then important will be the rehabilitation, because most of the time the patient after stroke, they remain paralyzed for a longer period of time. Their brain function reduces, and therefore overall their activities there decreases. So the next thing will be the rehabilitation. The remaining parts will go for the next time when about stroke. But as I told you, please go through, I repeat, please go through the cardiovascular system first, that is particularly various drugs which are acting on blood, coagulation, anticoagulation, etc., or antiplatelet, etc., and their use in angina and MI. If you go through this, then this will become comparatively easy, because it is only that organ is changing, and therefore some of the things are changing. Basic treatment remains same. So please go through that, and if you have any difficulty, you can ask me. Okay, take care, be safe.